when we're injecting the cervical and thoracic spine, we wish to have the patient positioned with a pillow lengthwise down the body. This elevates the ribs, allows the head to be flexed in a position that eliminates much of the cervical lordosis and gives us easier access to the spinous processes in the cervical area. So again, we want the pillow lengthwise down the body, as we have it here, not crosswise, so the patient can be relaxed. When we get down into the thoracic area, we can have the arms at the sides like this, or we can drop the arms off the table like this, and there's an advantage in that it slips the scapula sideways so that the border of his scapula is right here. Now I want you to put that arm back up, and that moves the border of his scapula over to here. And so there's some difference in how that moves the scapula off to the side. We're going to start with the cervical area, and I'm going to have you put your head in the middle. The head is in the midline. It helps to have a table with a cutout in it, but you can also put a little lift under the forehead so that the nose doesn't get too scrunched. We want to identify the midline, what we call the no man's triangle, the area in the middle where there's obviously space. We don't wish to put a needle in this area. Oftentimes I'll keep my finger in this area to keep my needle out of the area. We then want to identify the nuchal ridge where the skull turns and the attachments of the trapezius muscle lie along this area. We can mark this. And he has a rather indistinct nuchal ridge coming down along the side right to the mastoid being here. We then want to identify our spinous processes, and we drop down from that midline no man's triangle down into the area of the spinous processes, trying to feel the first spinous processes that's prominent, and that's C2. And it feels to me like it's right there, although on this patient I have some difficulty feeling that. Many times we can identify C2, and then the spinous processes below that we have difficulty with. Now I can prominently feel a spinous process right here, and on down here. And we come on down until we feel the prominent spinous process of C7. And in this patient, I can feel a spinous process here, space there, feels like a process there, one there, and there's probably another one lying in here. And then this is a large prominent spinous process. We want to mark the spinous processes and the interspinous areas so that we know where we're going to be putting our needle. And again, we're now down into the thoracic area. Sometimes it's difficult to tell when you're in cervical and coming down to C6 and 7 versus T1. And it is a bit difficult on this patient, but I think this is probably C6, probably C7 here. But we're not quite sure about that. The interspinous areas, interspinous and in the cervical area, it's the ligament of Nuki, and then the interspinous ligaments on down in the thoracic area. We then continue with our anatomy, knowing that the lamina of the cervical vertebrae lie approximately 1 finger breadth off the spinous processes. And so our second line runs just in a line down, again about a finger breadth off the spinous processes. Our next injection area is the area of the facets, and the facets are 2 finger breadths off the spinous processes. And so we make a second line. So we're about 2 inches out from the midline spinous processes. Another way to look at the facet line is where the neck really turns. And in addition to that, we can place 2 right angles, 2 markers over this area so that we have 90 degrees and making a 90 degrees angle here. And if we bisect that angle then and come directly down in between, directly down there, bisecting that 90-degree angle with a 45-degree angle, that's our angle to hit the facets out in this area. Our next anatomical landmark then is the second area along the nuchal ridge. We know that we have right directly on the nuchal ridge the attachments of the trapezius, and then underneath that, approximately a centimeter, the attachments of the splenius muscles. We can come all the way over to the mastoid process here. Most of the time patients are not sore quite that far over, but will have pain all along the area about down to a centimeter or two from the mastoid. Occasionally the mastoid will be tender and will need to be injected. In the cervical area then, the facets lie approximately 2 finger breadths off the spinous processes. The transverse processes then lie in a line from between the mastoid and the angle of the mandible backwards down into this area. So it's a line about like that, and we'll approach those when the patient's on his back. With the head flexed to reduce the cervical lordosis that we have, we can now begin our careful palpation. We know where our anatomy is with our marking, and so we carefully palpate for areas of tenderness. The patient has told us where the tenderness is in our history, but we can now palpate carefully where the tenderness is. We'll start along the nuchal ridge, and again it's very important to do a very methodical testing, pressing gently, not poking, and a slow, gentle press so the patient doesn't become confused about where you are. And asking the patient at each press, does that hurt? Does that hurt? Does that hurt? Does that hurt? And areas that are not in trouble ligamentous-wise will generally not be painful. So we've gone 2 lines along the nuchal ridge and inferior to the nuchal ridge. We now come down and do the same thing on our spinous processes and interspinous areas, and using either 1 finger or 1 thumb rather than the whole hand. We do not want to use the whole hand in palpation because the patient then becomes confused about where you're palpating. So using 1 finger or 1 thumb, we carefully palpate down. Does that hurt? Does that hurt? Does that hurt? Pain? Does that hurt? Does that hurt? And then we mark those spots that are painful, either with a different marker or a different type of mark, so that we know the spots that we're going to be injecting right down. And we carry this process right down through the spinous processes and interspinous areas, being careful to palpate both the spinous process, does that hurt, and the interspinous area, does that hurt. It's very important to do this meticulous palpation through the whole area that you're going to be injecting, because it's surprising that the patient may tell you 1 spot where they have pain, and yet when you palpate there are lots of areas where they find that they have pain. We take our syringe with our chosen solution. Again, we keep our finger in the below the inion, in the no man's land in the middle, and we find that nuchal ridge again, keeping our finger on the skin, palpating the anatomy. I can feel the curve of his nuchal ridge right in that spot. So then I come with my needle at about a 30 to 45 degree angle, so that I'm perpendicular to the bone. All injections should be perpendicular to the bone. I keep my finger on the nuchal ridge so that I know where I'm at with my injection, and then I enter with the needle and directly down onto the bone. In this area, this is a very shallow injection. The injection should not be in a caudal direction, but should be in a cranial direction, again about 45 degrees. We would then carry our injections out right along the nuchal ridge, either doing individual injections or doing needle withdrawal to the skin line and then redirecting our needle about 15 degrees, going back into the nuchal ridge, coming back out to the skin line, redirecting our needle medially and going back into the nuchal ridge. After we've done the first line along the nuchal ridge, we then drop a centimeter or so down and aim back in again to go deeper into the splenius muscles. This is a very safe area of injection, and even if you tried, you probably couldn't get into the cord in here, but we do want to stay away from the midline with that needle. So we're coming in and we do our second row of injections into the deeper splenius muscles. When we do this, we can do it in one of two ways, either coming in from the nuchal ridge injection and then coming back out and doing a second injection into the second layer along the nuchal ridge, or we can come into the nuchal ridge and then if there's enough skin looseness, we can slide the skin down and do a second injection, reorienting our needle a little bit more caudally, but again keeping in a cranial direction. And again, all injections are on the bone in both of these areas. We then would come to the midline and identify our C2 spinous process. We lock our fingers on the bone right at that spinous process. And the spinous process sits right between my fingers. These are not very big spinous processes, so sometimes they're hard to hit. This will not be a terrifically deep injection. And our direction of our needle is caudal, never cranial, never straight down, but always caudal in this area so that we're aiming down toward the tailbone. The injection goes slowly in toward the spinous process, hitting the spinous process and doing our injection. We then come back out and we can go down to the next spinous process, which I can feel quite prominently here. And again, with my fingers locked over that spinous process, so I can feel it right between my fingers. I come in directly onto the spinous process with the needle. I can then come back out to the skin level, which is an important concept. If you do not come out to the skin level with the needle, not out of the skin, but just below the skin, so the needle is just subdermally, you will be in the fascia and your needle will simply bend and go down in the same track. So you come out to the skin level, skin slide down, and go back in between the spinous processes into the interspinous area. We then come back out and move down, on down to our next spinous process, and repeat that procedure, moving down gradually with our fingers locked. Again, skin compression, so we're moving the skin in and hitting the spinous process, the interspinous area, the spinous process. And here we have much looser skin so that we can slide the skin down and actually go into the interspinous area with one injection site. But again, it's critical to come out to the area of the skin rather than out of the skin, but above the fascia. You'll sometimes feel the needle pop out of that area. Other times, if you try to slide, the needle will bend if you're still in the fascia, and if you re-inject, you'll go down in the same hole. So it's important to get the needle out far enough before you do your next injection down into the interspinous area. Then in the cervical area, we've now done our nuchal ridge, our second line along the nuchal ridge. We've now done our spinous processes and our interspinous areas in the cervical area. We then come into the laminal area, not the facet area, the laminal area here, about 1 finger breadth off, halfway between the facet area over here and the spinous processes. This is a broad area of bone that again is flat and usually relatively easy to hit. In this area, we place our fingers on the spinous processes, and then we come in with our injection at approximately a 30 to 40 degree angle, going straight down, making sure that we're below C2 with this. We know that there's open space above C2, so we want to be at C2 or below or lower. C3 is even safer in this area. You may maintain a little bit of caudal direction, or you may just inject straight in with, again, a little bit of medial orientation, 20 or 30 degrees off of the midline. This is perpendicular. This is about 30 degrees in toward the midline. We just walk down then with multiple injections, usually 4 or 5 injections, down in a row down this area. We then move to our facet area, and again knowing that we're going to stay below C2, if we think this is C2 right here, and stay below that area because of the vital structures and the ease of getting into the cord above this area. The vertebral artery also comes up and is quite open in this area. Our injections here again are 30 to 45 degrees medially. Here's perpendicular, and the injection is about like this, going in gently till we hit the spinous or the facet in this area, and then we walk down with 4 or 5 injections on the facets right down the cervical spine. We know then that when we get below this area, our facets move inward or medially to come just 1 finger breadth or a centimeter or 2 off the spinous processes in the thoracic area. When we're palpating the C7 tip of the transverse process, we come in front of just in front of the trapezius, press in fairly firmly, and people will let you know when you're on it. There's the process right there. And so it's a deep structure, but you can press in quite firmly, and then with the needle aiming caudally and toward the spine, we come backwards and upwards just very superficially onto that tip of the spinous or the transverse process of C7. It's just above the first rib, and if we move on out then, pushing the trapezius backwards, we come down onto the first rib. He has quite a deep first rib. It's hard to feel, but it's right there. And our injection then is backwards and upwards onto the first rib. We want to maintain our backward direction with the needle, so we're aiming dorsally on the patient and upwards so that we don't slide into the apex of the lung. The second rib lies in the trapezius, right in here. The scalenes come off of this area, so this first and second rib are important ribs to hit. And again, with our needle aimed backwards and upwards, we come into that second rib. These injections can also be done in the sitting position. We talked earlier about doing the injections of the C7 transverse process and the first and second ribs in the sitting position. So if we push the trapezius back and aside, and we come in and find the bump of the C7 transverse process, it's right there. One has to push in quite firmly in many people to hit it, but that's it right there. And it's a firm bump, and if you drop off it then, right there you're on the first rib, and that can also be quite painful, the scalenes coming off this area. So to inject this area in the sitting position, we come in and find that bump. You can use a 27 gauge needle, a shorter needle here. This will not be a deep injection. Keep your finger right on the bump and come in aiming a little caudally and a little medially, right down in front of your finger, right onto the tip of that C7 transverse process. We then just drop off it, and we're on the first rib, and so our injection here again is toward the back dorsally and caudally, coming down onto the first rib to avoid the apex of the lung that would reside in this area. Then, as I mentioned before, from that C7 transverse process right there, right on back here is a ring of bone. And so I'll just walk my needle around with impunity right back to the facet area next to the spinous process where my thumb is. And that ring around the collar right there is often a very exquisitely tender area that has to do with stability of the neck. Our next move is down into the thoracic area. We know that once we have found that C7 transverse process right here, we know that there's a ring of solid bone right around this area down to the T1 tip of the spinous process. And so once we've hit that, then I'll just walk my needle right in a line backwards like this. I have come to call this the ring around the collar, and it's often a very tender, sensitive area in people with neck and upper back pain. And so I think it's important to progress from that area right around to the area of the facet in the upper thoracic area here. We're now going to consider the injections of the tips of the transverse processes in the cervical area. These are bifid, and nerves come out right through them, and of course the vertebral artery runs right in this area as well. We identify the angle of the mandible right here, and the mastoid process, which is right here. And we know that the tip of C1 lies right between the two. It's often tender. People feel tenderness, but in people who have problems there, it's exquisitely tender. We can push in this area and go with our injection directly down onto the tip of the transverse process at C1. This will not be a deep injection, and one should not probe deeply in here. The styloid lies right under this area. The transverse processes then form an angle, and then angle backward to the C7 transverse process, which, as we pointed out earlier, becomes more prominent and more posterior. We can feel those by bringing the sternocleidomastoid forward and bringing our fingers down, and we can feel the pillar of these transverse processes, probably the anterior portion of the bifid bone. Usually people are tender from about C3 on down in that middle area. For safety purposes, we wish to stay 2 finger breadths above the clavicle in this area because of the possibility of the apex of the lung coming up into that area. So we're looking then at a line, and we can feel that line of bone right down here.